So good morning, everybody, and thank you very much for inviting me to talk at the NPEC meeting. My name is Dr Anne Twomey, for those that don't know me, and I'm a consultant neonatologist in Holles Street. So without further ado, I might go forward now and start my presentation. So the title of my presentation today is the Very Low Birth Weight Infant Clinical Audit. And as you know, the theme of the NPEC study day is from recommendation to implementation. So what I wanted to do in this presentation is very much focus on what we've learned from our clinical audit, what recommendations we've made, and how we've gone around to implementing those and what improvements we've seen. Now, as I said, I'm a consultant neonatologist working in Holles Street, but the work that I'm presenting here today is very much on behalf of the NICOR Ireland Group. And the NICOR Ireland Group are a group of paediatricians and neonatologists from around all the centres in Ireland that are delivering infants and are contributing data to VON, and they supervise this audit, and also on behalf of NPEC, who carry out the statistical analysis and prepare the report. So I thought I might start off by actually making just reference to one or two quotes. Now, the first one is attributed to Lord Kelvin, the well-known scientist, who said, if you cannot measure it, you cannot improve it. And I think this is really, really important for our very low birth weight outcomes. If we actually don't know how common these conditions are, and we don't have a handle on how frequently they occur, then there really is very little hope that we can start making improvements with these infants. And I suppose that was very much struck that a lot of the centres, about 9 centres around Ireland, had been collecting data about 10 or 15 years. And we all got together and said, well, what are we doing with this data? What's the point in collecting data unless it actually makes a difference? And at that meeting, even though there's only 9 centres present, the unanimous decision was that we needed to create a national data set. And it was from that, basically, that the NICOR group collaborated with NPEC and ended up that every single centre in Ireland started contributing data to the Vermont Oxford Network, a very large multinational collaboration. And it is hoped then, the idea was that once we had national figures, we'd be in a much better position then to see what our outcomes were and if we could make attempts to improve it. The other thing that I think is critically important is the other quote there by Daniel Keyes-Moran, who's a computer scientist, who said that you can have data without information, but you cannot have information without data. And again, I think that is another really important point. In other words, we can collect lots and lots of data. We can have every single incident and number under the sun. But if we don't attach meaning to that data or use that data, then it's worthless. And that's the whole point, that there's a lot of time and effort put in by lots of people around the country collecting this data, cleaning the data. But unless we use the data and apply the information or from that data to actually make change, then it's a waste of time. And I suppose that's what very much this conference today is about, is saying, okay, well, we've collected the data now. How are we actually putting that into making changes? So based on the NICOR collaboration with NPEC, our first annual very low birth weight report was published in 2014. And this involved almost 600 babies. So, and it was published in early 2016. Now, unfortunately, the key finding from that particular report was that actually our mortality rate was higher than expected. So let me just make a quick reference to what an SMR is. An SMR stands for a standardized mortality rate. Now, when you contribute data to VON, you find out what your instances of, we'd say, mortality. So maybe 85% of babies survive, 15% of babies die. But if you then want to compare yourself from one centre to another, you might say, oh, well, look, the reason why my mortality rate in our centre is so high is that we had much sicker babies. We had lots of 23-weekers, or they were all very small, or we had an outbreak of infection. So the actual number itself is really meaningless. So to actually be able to compare yourself between centres, you need to take into account the case mix. And that effectively is what a standardized mortality rate does. So Vermont Oxford takes our data, and then they correct it for the birth weight, gestational age, if the baby has had a congenital anomaly, if they're outborn, for a number of different factors that may impact on mortality. And then they give us a standardized rate. So if the rate for our country is greater than 1, you have more cases than would be expected based on your case mix. If it's less than 1, you've less cases than would be expected. And if it's exactly 1, well, then you're the same as every other centre. So our key finding in that report was that our standardized mortality rate was 1.27. And as you see, the confidence interval is above 1. So you were significantly more likely to die as a very low birth weight in Ireland compared to the Vaughan network. And that was a fairly startling finding at the time. Now, if we excluded babies' early deaths, and that's a death that occurs in the first 12 hours of life, then there was no significant difference. And then the key other figure, death or morbidity, the standardized mortality rate also was significantly high at 1.14. So we needed to understand why that might be happening, and was there any clear explanation? Well, again, looking at the data at that time, it found that more of our very low birth weight infants died in the delivery room compared to Vaughan, and that was 8% compared to 4%, and that p-value was very significant. And 72% of the ROI infants who died in the delivery room were less than 24 weeks gestation. And 88% of babies in the Republic of Ireland who were less than 24 weeks that died in the delivery room, 88% of ROI babies less than 24 weeks who died in the delivery room, and that's compared to 39% for Vaughan. So, and that was also very significant. So lots of ROI babies were dying in the delivery room, and they were, and that was certainly different from the network. So when we got this information, we then needed to decide, well, what we're going to do with that. So we report that information back to the Neonatal Advisory Committee of the Faculty of Peds and to the Institute and to the leads in neonatology and obstetrics. And on the basis of that, they said, well, rightly so, you can't make any recommendation based on 1 year of data. You need to collect a couple more years. And they asked us to do the analysis again after having about 3 to 5 years of data. And the other thing is that they actually convened a working group to specifically look at the management of babies at the age of around the peri-viable or at the limits of viability, and about how we should be managing these babies in the best fashion. So we went ahead then and we collected the 3 years of data, and then we did an analysis of the composite 3 year of data, and we produced the very low birth weight in infants in the Republic of Ireland report, and that was published in 2018. Now, again, the key findings in this report, and now we had over 1,800 babies. Again, the standardized mortality rate, as you can see here, was 1.15. So it was a little better. So it had come down from 1.27, but it was still significant. Again, if you excluded early deaths, there was no difference. And death and morbidity, again, just was significant. So the finding was still there, but maybe somewhat better now that we'd included 3 years of data. Again, if we look down to where these babies were dying, we could see that 7% of our babies died in the delivery room compared to 3.4 for Vaughan. Pretty much the same number of died after or within 12 hours. And then mortality excluding early deaths was pretty similar. So again, our death rate seemed to be very much concentrated in what was happening in the delivery room. And that finding was very significant. And overall, of those who died in the delivery room, 68%, that's 87 of 129, were less than 24 weeks. So based on those findings, our 3 year report came up with some key findings. The first key finding was that very low birth weight infants born in Ireland between 2014 and 2016 were indeed more likely to die. But the excess mortality at 22 to 23 weeks was almost wholly due to infants who were not resuscitated. So these babies were dying in the delivery room because we weren't offering them resuscitation. And that was certainly different to what was happening internationally. So our key recommendation at this point was that women who are anticipated to deliver at 23 weeks should receive antenatal steroids and magnesium sulfate, and the neonatal team should be alerted prior to delivery. And then resuscitation should be administered to all infants born at 23 weeks who present in a favourable condition. And obviously that would be based on a discussion that would happen with the family and taking all clinical features into account. This recommendation was then further substantiated by the consensus guideline that was produced by the by the working group, and this was called the Perinatal Management of Extreme Preterm Birth at the Threshold of Viability: A Framework for Practice, and that was published in 2020, based on data from our reports, our clinical audit reports, but also from international studies as well. And this is of huge benefit. It provides much greater clarity and consistency in perinatal and neonatal management of these babies. And it's an extremely useful document for all people that are working on the front line. So based on that work, then, I suppose I thought it would be interesting to look at the trends in resuscitation, or what's been happening over that 6-year period that we've been doing the audit. Now, if you start off and you look in 2014, at that time, 42% of babies were offered resuscitation. And if you follow that blue line, it's now close to 83%. So almost double the number of babies at that gestation are offered resuscitation in the delivery room. And pretty much if you're offered resuscitation, the red line, most of those babies will end up being admitted to the unit. So again, up to 80% of these babies actually are admitted to the unit for further management. If you look at the number that survived to discharge, our survival rate in 2014 was 19%. It has now increased, and in 2019 was 35%. That is an 84% increase from the baseline. Now, that if you had a drug that offered an 84% increase in survival, you'd be a millionaire. So I think the point being here that just by us looking at the audit, looking at national and international practice, and making a recommendation to provide resuscitation at this gestational age, we have improved survival by a factor of 84% in that gestational age group. If we look at the trends in delivery room deaths, then, as we started off, it was 8% at the start. That dropped down to 6%. In the last year, it did go back up to 8%, and we're looking at this further. And importantly, deaths in the less than 24-week infants in the delivery room decreased from 6% and has remained pretty much around 4%. There's a number of deaths that occur in the delivery room because of major congenital anomaly, MCA. That was anywhere between 1% and 2%, and it was a little higher last year, accounting for the increased number of deaths. We'll be looking at this trend in the coming years. So the 3-year report also came up with another key recommendation, and that was based on its second finding, that infants born at 24 to 27 weeks gestation who were not born in one of the 4 tertiary centres, the 4 tertiary neonatal centres, had a 70% higher mortality risk than expected. That's an SMR of 1.7, and that was highly significant. So based on that finding from that report, we recommended that infants born less than 28 weeks gestation should ideally be delivered in a tertiary neonatal unit. And that was in line with the current model of care for neonatal services in Ireland that had already been published. And so it reinforced that recommendation. Again, what's been happening since that report was published? Well, in 2017, we had 78% of our babies, our very low birth weight babies, were born in a tertiary neonatal centre. That has improved just to 80%. Effectively, it's not really changed. And 20% of babies in 2019 are still delivering outside the 4 centres. That's 1 in 5. That's a fairly significantly high number, especially when we know it's associated with a higher mortality. So it does seem that that recommendation has not yet been taken on board. And I suppose, again, it's at days like today where we can just really emphasize that point and say it's really important that these mothers preferably are transferred in utero to one of the tertiary centres in anticipation of delivery, and that we really need to get that message across to our obstetric colleagues and to our neonatal colleagues and pediatric colleagues around the country. As we hadn't really seen much of an improvement, at the last NICOR meeting, we were looking at this data. We have now made a request to the NWIP programme, and we've asked them to consider adding it as a data item to the National Irish Maternity Incidence System. So basically, each hospital around the country reports to NIMS on a number of factors like caesarean section rates, caesarean hysterectomy, so forth. And we are now asking them, would they ask each hospital to report any delivery of an infant less than 28 weeks gestation that occurs in their hospital? Because at least then, if we're collecting the data, we can actually find out why are those babies delivering there. Some we will not be able to prevent. The mother presents with an acute abruption or is fully dilated, but other cases it may be due to delays in maybe having staff to transfer the mother or ambulance access. We don't know. And while we now have data, we now need to get information. We need to get more about that particular group to see if we can make a difference to these infants. So again, just I thought this would be worthwhile showing again. So what's happening to our standardized mortality rates over the last 6 years? And like I told you, that first year in 2014, we got a bit of a shock because it was seen to be higher. Then it came down in 2015 to 2016. So we were reassured by that. Stayed pretty much at that level between 2017 and 2018. But then the last year that we have done, and this is at a time that we're now offering resuscitation to a lot more 23-weekers, and we were hoping that would actually, improve our standardized mortality rate. But I suppose with some disappointment in the last year of reported data in 2019, that SMR is back up to 1.29 and is significant. It may be that the babies that we're resuscitating at 23 weeks aren't surviving, even though 35% of them now are surviving, there's some other factor going on. So again, we need to keep looking at the data and need to look at reasons for that. Again, we've had this discussion. We need to explore this further. And what we now plan to do is to undertake an analysis of the entire 6 years of data, looking specifically at mortality, because again, one of the big challenges here is numbers. We're talking about small numbers in each category. So we need probably up to 6 years of data before we can take under another meaningful analysis. And we hope to publish on that later on this year. I think it's really important now to mention neurodevelopmental outcome. If we are going to be offering resuscitation at 23 weeks gestation, we need to know how these babies do long term. How can a family make an informed decision about proceeding with resuscitation unless they know the possible outcomes? I would have to say that neurodevelopment for the very premature population in Ireland has been poor and patchy to date. Some centres do not routinely follow up these infants to 2 years. Others do, but again, that information, it's hard to get. As we know, the gold standard is the Bailey assessment at 2 years corrected age. With COVID, because we can't be doing face-to-face assessments, we are now looking at the PARCA or questionnaire, and we probably will be reporting on that in the future, but the Bailey's assessment still remains the gold standard. Based on the fact that we had now a consensus that we were recommending that we should resuscitate at 23 weeks, we had a consensus document supporting that. We then subsequently made a business case to NWIP saying that if we're going to do that, it is imperative that we have good neurodevelopmental follow-up. Based on that business case, we are very happy to report that NWIP agreed to fund 3 psychology posts. They have been funded. That funding just came through, believe it or not, just before COVID hit in 2020. So there has been some delay in hiring people, advertising posts and getting them filled. But the funding is there, and we are very hopeful now that we will now have national follow-up data as part of the annual very low birth weight audit. The purpose being that these psychology posts, in addition with what's currently in place, will actually provide national coverage and ensure that all these babies get appropriate follow-up. Which I think is a really, really important step in the right direction. I just want again, what else have we learned from the audit and what other benefits? And again, I would just, now that we have data and we have several years of data, we're now able to produce composite tables that are really, really useful, I think, to all the centres around the country, both the neonatologists and paediatricians and the obstetricians. So here's just one example of the table that you have at each gestational age. You have the actual numbers of survivors to discharge, and we now have almost 3,500 babies, which is a huge number of babies. Here we can give the actual percentage of that survive. So if you look at 23 weeks, 33% over these 6 years have survived, and we can compare it to a Vaughan percentage showing that we're a little bit behind their figure is 43%. And I think this is really useful information when doctors are making decisions to transfer women to tertiary centres or talking to women and giving them some advice about what to expect. We now have Irish data and we can compare it with international data. We also have the same data for birth weight. Again, this is particularly useful more to the obstetricians because they often go by birth weight when they have when they're doing ultrasound. And again, for any particular birth weight, 100-gram category, we can actually give the family a percentage of what their survival is based on the last 6 years of Irish data. What we are planning to do for next year, again, and this is again based on feedback, is we're going to divide these babies with birth weight into those that are appropriately grown for gestation age and that are small for gestation age, because we know that's another factor. And again, that'll be very useful information for families and for doctors and clinicians when they're trying to give the family good advice. Another advantage of the audit is that we can look at survival without specified morbidities. That means any baby that survives without a severe IVH, chronic lung disease, necrotizing enterocolitis, pneumothorax, a late infection, or periventricular leukomalacia. Now, when the advantage of having NPEC hold this data set is useful because we're now able to analyze data as relevant to the Irish population. So if we use the Vaughan reporting system, we're very much tied into their groups, and they tend to look at babies less than 24 weeks and 24 to 26 weeks. It's much more appropriate for us to be able to look at 23 weeks gestation because we don't offer resuscitation at 22 weeks, and then look at the 24 to 27 weeks gestation, which ties in with our model of care. So we were able to do this analysis because of this data set, and we were able to say that in 2014, there was no infant that survived at 23 weeks that didn't have a significant morbidity. That figure is 7% in 2019. If we look at our 24 to 27 weekers, the original figure was 27%. That's improved somewhat to 35%. And again, this is just very useful data for us to have, both to counsel families, but also to look at how we are doing over time and where improvements need to happen. I thought these two slides were useful just to show again the importance of the audit. These are the standardized morbidity rates. So again, we do the very same thing for certain key performance indicators, one of them being coagulase negative infection. And we standardize our rates, so we're able to compare how Ireland does compared to to the Vaughan network. And if you look at 2014 and 2015, we had a very high incidence of coagulase negative infection, significantly greater than would be expected based on our case mix. There was a lot of attention, as you know, this time nationally on infection and central line infection. There was antimicrobial infectious disease input. And look, if you look now, our SMRs for coagulase negative infection are just all crossing 1. They're all approximately 1 and not significant. So that again is just showing you that changes can happen and do happen if we measure and introduce good practices. And that's been very much based on attention to the following: hand washing, good hand washing technique, good aseptic technique when we are placing IV lines, and then care bundles looking after for central line infections. SMRs for pneumothorax I thought was interesting to present because basically every year except 2016, Ireland has a significantly higher rate of pneumothorax compared to its compared to the network. And again, that's a really interesting finding. We are not sure why. Why should Irish babies have that completely high instance? And again, I think that it is certainly something that needs to be looked at. And now that we have 6 years of data, we're now starting to get to a data set that will allow us to make some meaningful interpretation. So what can I say, a summary of what's been achieved to date? Well, we now have a national data set that spans 6 years involving about 3,500 babies. It allows us to benchmark our practices both nationally and internationally. We now have figures that we can actually really bury down into that information into and get real information. The excellent thing is that raw anonymized data is returned to the NPEC. So NPEC are in charge of the data and can analyze the data as best suits our country and Irish babies. We now have a perinatal management of extreme preterm birth at threshold of viability, a framework for practice that's been published. That was published in 2020 and was very much based on our findings in this clinical audit report. We have made significant progress, I believe, on having a national neurodevelopmental follow-up program for these preterm infants, and we hope to be able to report on those outcomes in coming years. And again, the data set now is large enough for us to look again at mortality over a 6-year period, and also at specific morbidities. And very much what we need to focus on the next couple of years is pneumothorax and necrotizing enterocolitis. I'd just like to take this point to thank everybody that's involved, in particular all the data collectors, all the nurses and doctors around these centres who collect this data all on their extra time. And it's just so important. And we really want to say thanks very much to them, to Sarah and Paula in the NPEC who actually produce these reports and produce all the data analysis. And that's on behalf of the NICOR Ireland Group and NPEC. So thank you very much for your time. And I'm happy to take any questions.